Explant this morning. Very interesting. So this is a lady in her late 40s, 47. She had implants in 2009 silicone from the axilla, from the armpit approach. And so these were below the muscle. And she had a workup that showed an MRI which showed that the right side was ruptured. Now there's this she did on her own. The left side was intact. Now, as you will see, 100% total capsulectomy done, 3-6-25 initials HG, 2009 silicone, below the muscle, axillary incision. Now, as you will see, look at this, the way this looks. This is the implant. And as I was dissecting, you will see right here, I'm going to put the entire, technically end block was done, except for this axillary area. There was a very thin capsule that essentially broke. You can see this small crack right in the middle. I was able to take this and put it here, and then I continued the dissection around. So as you will see, none of it spilled into the chest. She did not need, and I will tell you, it's super tricky, because if you look over here, very, very, very thin capsule. And if I lift this up, you will see this extended all the way into the armpit area. So that dissection around was so tricky. One of the most involved implants. And you can see, look how this implant is contained. None of it has spilled. Even if you look over here, look how super thin. It has not come out of its shell. This is how thin, that super thin that capsule is right here as I press. Now you will see, I'm going to actually use this small area, and you will see how it's literally going to disintegrate. You can see how thin this is. If I put my scissor, you can see it can easily spill into the chest. And look how this implant kind of adapted the contour of where it went from the axilla. And none of this spilled into the chest. It was all contained. And you can see literally there is nothing cohesive about this implant. And it literally, imagine if there was an extra capsular spread. Look at this ball right here that was all contained that we saw. And so this stretched into this. It is cohesive, but not cohesive enough, as you will see on the left side. So this is all contained by this ultra thin, super thin capsular tissue, and it was very, I use the word, painful dissection, where all of this was contained. You just saw that area that was sticking out. This is that area. Look how thin this is, but no break, except for the very end part, where I was able to plug this. So none of the silicone spilled into the chest. Now, the other thing I want you to watch out for is you can see it's going to spread out. So it's somewhat molten, if you will. So we will see it in a second. I'm going to go ahead and change my top glove. And look how it's literally spreading out. So you can only imagine if she has, you can point to it. If the patient has had an intracapsular rupture, all of it is contained within the capsule. Let's say if she is riding a bike and someone hits, it can then become what is extracapsular. So someone who had an MRI done, already given her workup, and she had an intracapsular rupture, you do not want to have potential trauma, someone playing basketball or a car door swinging open on a windy day and hitting the side of the chest and now causing an extracapsular rupture. Obviously this will spread outside, and so look how it's kind of spreading out. I'm going to go ahead, and I have new gloves. I see some surgeons use non-sterile gloves. There is a biofilm on the inside. That's what I get the cultures off, so we can get a good representative sample. This is the full thickness scan right here, and I've removed the entire implant. This is certainly the nice cohesive implant as it went in. some fluid around. If I go like this, you can see the stickiness. This is that leaching of that silicone from the implant, which is intact, that is going into the periphery. So this is your 325 Mentor implant intact. I will tell you, this is so strong. Even if I hit it, and I hit it with this sharp edge, it's not gonna break. But you leave it incubating in the body for a period of this, how it's disintegrating. You can see the shell. If you leave it out here for another half an hour, you're gonna see it's gonna spread out, and this is not cohesive. There is a non-cohesive component to it, and it's more gel-like, like semi-hot honey. So going back to this capsule, you will see, look how thin this capsular tissue is. The goal here is to remove all of it. And the surgeon always has to go in thinking that the implant is ruptured. So a few learning points. Number five things to learn from this case. Number one, yesterday's case, the MRI was done, as you saw the Facebook Live, and the MRI said that the right side was ruptured. And the MRI was wrong yesterday. Today, the MRI that the patient had on the right side, it indeed was ruptured. So the MRI can be wrong. In this case, the MRI was right. Number two, the surgeon always has to go in thinking that the implant is ruptured, even if the MRI says it's ruptured or not. So that is the second point. Number three, the entire capsule, no matter how thin it is, has to be removed. Someone cannot say, well, the capsule is thin, I'm going to leave it behind. No, the whole capsule must be removed, so you have the peace of mind that there is no capsular burden, inflamed burden remaining behind. I got a pathology report from another patient that said within the capsule was some silicone particles, and that tells you that that must be removed, otherwise that immune reaction will continue. Number four, no matter what length of time it takes, the surgeon must continue to dissect in that nice avascular bloodless plane, and even if it's ruptured and there is an inevitable break in the capsule, it can be always plugged in. And no matter what, the capsule must be sent to pathology so that we rule out that very rare BIL, CD30 analysis is done, rule out lymphoma, rule out malignancy. And I find that majority of the plastic surgeons are not sending the capsules off to pathology. Even if they are sending it off, the CD30 analysis is not done, and so there is some potential under the reporting of the BIL-LCL, which is very well established in the medical literature and the medical plastic surgery community. So there you have it. The capsules will be sent to pathology. Like I said, there was no fluid, luckily. The implants will be returned to the patient, and cultures for bacteria and fungus between the implant and capsule will be done so that we can find out about aerobic, anaerobic, and fungal. So a complete thorough workup, and you can only imagine how, quote, relieved this patient is going to be. She had a lot of symptoms of breast implant illness. And again, if you look at this implant, look how it's spreading out, disintegrating. It's not cohesive. Look at the color of this implant. And if I took a baseball bat and I really hit it hard 100 times, it's still not going to rupture. But the same implant in the body, over a period of time incubating, it will disintegrate and it will break down, just like the older technology. This one, yes, it's a little bit more cohesive, but not good enough. This is Dr. Khan, executive plastic surgeon.
Scared me.